graphical analysis to guide in treatment planning. Our next speaker is a senior consultant at the University Spine Center, Department of Orthopedics, National University Hospital, and Healthy Aging Program at the Alexandra Hospital. He is assistant professor and research director at the Department of Orthopedic Surgery, Yong Lu Lin School of Medicine, NUS, and a spine care faculty of the postgraduate residency program at the Department of Orthopedics, NUHS. May we now welcome Mr. Dennis Hwee Weng. Can we present his?
Good morning, everyone. Thank you for having me talk about this topic on biomechanical radiographical analysis to guide in treatment planning. These are my disclosures. I think to start off, we need to know what we don't know of the spine. On the left picture shows you the spine, which is what we know with the cervical lordosis, thoracic kyphosis, lumbar lordosis. But what we don't really appreciate sometimes is the alignment of the spine, which varies in the individual. So yours is different from mine. We have to look at the individual specifically. With age, as we age, our alignment changes, as well as with posture. This is something that's very, very important, but always not being paid enough attention. This is an X-ray of a patient who's 61 years old with the parameters measured. The next picture shows the same patient 6 years later, 67 years old. I can see some changes in the alignment, particularly the thoracic spine goes into more kyphosis. The lumbar spine goes into less lordosis, the increase in pelvic tilt, as well as the forward move of the SVA. Okay, these same changes in the parameters is actually already seen in the sitting position alignments shown in the last picture, suggesting that sitting position of the spine may be one of the main reasons how we drive our alignment over as we age. And if you look at the picture on the right side again, these are pictures of the person standing slouch in the natural slouching position, as well as an elderly in the slouch position, in the normal position. So again, the parameters are very similar with the thoracic increase in kyphosis, the reduced number of lordosis, and the increase in SVA in the slouch position, again showing us that maybe not in the sitting, but in the standing slouch position, actually naturally assume most of the time for most people, also drives what happens to us in the future. So day-to-day activities and postures, understanding of spine dynamism drives age, called age changes in alignment. And hence, age-adjusted undercorrection is merely just a reflection of respecting dynamism of the spinal alignment. And we really need to pay attention to the spinal alignment in different postures rather than age. And since PJF doesn't exist only in elderly spine, even also in young patients, hence why should we only undercorrect in the elderly, all right? So based on age-adjusted values, look at it. So this is a shout. To me, it's very clear, a shout to all to look seriously into the dynamism of the spine and not indulge too much into age-adjusted values. These are X-rays showing the patient standing and patient sitting. Most of us will do X-rays of the patient standing on the left-hand side. And reference to that, we will do our spinal realignment as shown here. We did a good correction of the alignment, but in the sitting position, we have generated a deformity, illustrating a point, once again, that the spine moves, that if you do a strategy like a treatment of fusion that locks the spine, will always generate a deformity and causing stress. And the stress is going to be kyphosis at the proximal junction. So our studies in the standing and sitting position X-rays showed these findings. Okay, so the first picture is on the standing position. The second one is on the sitting upright. The third one is in the sitting slouch position. As we move from the standing to the sitting slouch position, you can see that the apex comes together. The apex of the thoracic spine and the lumbar spine approximates. And there's a kyphosis force going from top to bottom and a lordosis force going from bottom to top, with the top force being stronger and swallows the bottom force. And hence I call it the big wave swallows the ascending small wave, all right? So again, it depicts the fact that there's always a kyphotic force coming from the cranial portion, resulting in our PJK most of the time, as well as a retroverting force of the pelvis from caudal causing DJK sometimes, which is less common. This is the protocol that I do in my institution, designed by myself, okay, where you include a series of EOS imaging. You can see the first one is fulcrum standing from T10 to knee. We have the standard, the AP lateral of the full body. We have a slouch standing lateral position of the full body, as well as a whole spine lateral position showing a slump sitting flexion, okay? And the understanding of the spectrum of the spine's alignment over the day-to-day posturing can be seen between these two orange boxes, where most of the time we are in this region. The spine changes in shape between these two regions, and the boxes tells us the extremes of these changes. Or the red boxes telling us the maximum potential for extension and flexion, the fullest capability of the spine in flexion and extension. So this gives us all the information needed for that particular individual of a certain age, based on the postures that he may assume in day-to-day activities. And of course, if you want to be even more individualized, you can ask these specific questions on the occupation, how long he sits and stands, what's the pastimes, what is the sport, as well as other postures like squatting, which may be common in Asian populations. These are all evidence-based already because they've been published. Okay, I think I want to draw your attention to some key angles here that you need to pay attention to, which is not classic in conventional teaching. The first one is HL in the left picture. HL is hip lordosis. It is actually the lordosis generated at the hip joint, which is almost analogous to what we call a hip extension. The reason why we look at this is because we understand that there is lordosis at the hip joint. As a result, this is a confounding factor. You may not need to generate so much lordosis in the spine because there is already lordosis residing in the hip joint. The spinal coxal angle is a functional angle showing in a normal standing position what may be the lordosis at that segment truly, okay? As well as the last one, which is the T10 slope and the T8, T12 kyphosis angle, really is a depiction of the slope angle and where the UIV may be, okay, or at the junction, the kyphosis angle. All right. So if you were to stop at T4, that was a strategy because the deformity requires to stop T4. You would therefore look at the T4 slope angle or the T2 to T6 kyphosis angle, 2 levels above and 2 levels below, to tell you how you should generate alignment at that junctional region. Okay. So I do understand that most of you do not have EOS images sometimes, and you use X-rays. So this is the proposed X-rays where you do fulcrum extension standing up to T10 still, but not including the lower limbs. You can do long films, AP and lateral, but I would advise you to do it in the slouch position. You can do the flexion slump sitting, again up to T10, but without the lower limbs, right? So with this protocol, you realize that the hip lordosis angle, which we mentioned earlier on, the HL, could not be measured anymore. So you lose that information. This is something that you have to forego if you do not do a full body EOS. The spinal coxal angle is not relevant, okay, in most of the cases, so you could omit it. Okay, only in exceptional cases you look at it. But you would definitely have the angle such as the T10 slope and the T8 to T12 kyphosis angle, assuming that you would want to stop at the T10 level. So all these things tells you the information that is required, and you were to do this correction strategy. You will also try to assume correction to within the cone economy by generating lordosis in the lower lumbar spine, making sure that the lordosis is as caudal as possible, ensuring that there is not overcorrection because some of the lordosis in the hip as well. So you want to go for less lordosis, shorter lordotic span, as well as a lower lumbar apex to allow accommodating segments higher up, because you know that you're going to fight a battle in the cranial portion at the junction. So remember the T10 angle we're talking about and the T8 to T12 angle, COP angle to dial in as you try to accommodate the junction to the natural of the spine. So to have a correcting segment, which is in the lower lumbar spine, as well as the kyphotic segment, based on the angles we mentioned earlier on, to tackle with the junctional force from above. I just want to stress that studying all these sitting alignment does not mean that we are trying to assume a sitting position, but trying to understand how much to accommodate, and the extent to accommodate is key to preventing PJK and PJF. And finally, these are the strategies commonly done with the UIV at the L2, T10 or T9 or T4, trying to either preserve motion at the thoracolumbar junction or to allow bridging into the thoracic spine, or to allow some distance away from the thoracic junction to prevent altering of the mechanics over there causing PJK. So the take-home messages really is that conventional understanding of spinal mechanics needs an overhaul, I think. Modern literature adds a lot of noise, okay, than help. Deformity is a moving target simply because the spine moves, it's meant to move. So motion preserving stability is the ultimate solution to the problem. Simplification of the problem through studying of key postures such as standing and sitting, radiography, as well as natural tendencies like relaxed postures reduces complications substantially. Accommodation to sitting and relaxed alignments, both cranially and caudally, is crucial for better outcomes. And finally, PT is a parameter that I just want to say that is severely misunderstood. So clarification is a pivotal step prior to surgical planning, which can be talked about in another lecture. Thank you very much.
So that was an excellent lecture by Dr. Hwee. Zoom? Yeah? Oo nga, pero oo nga, pero naka-zoom na siya ngayon. Oo. Pero we'll have the question and answer now for this or Dr. Simrano? So we'll do this one first. Okay. Before we go for the Q&A, we'll have another lecture by one of our colleagues from across the Pacific Ocean. Our next faculty is Dr. Jonathan N. Sembrano. He will be talking about decision making.
Hay presenting the indications for limited stabilization.
Very good afternoon to all. Thank you for having me talk about this topic, indications for limited stabilization. These are my disclosures. This topic really asks the question, when do we instrument? When do we instrument short? When do we instrument long? Okay, and I thought to approach this asking ourselves these questions. There are situations whereby there are disease pathologies that are very focal. We talk about whether we do decompression alone or when do we add on fixation. Sometimes there is a scoliosis at the same time with a pathology. And we ask ourselves whether to deal with the pathology alone or should we just ignore or address the scoliosis at the same time. This is where we need to decide whether to instrument just the L4-5, which may be shown in this picture, L4-5 fixation, or should we go even higher because there's a problem of a scoliosis, perhaps up to L2, okay, or even higher. Sometimes we stop at L5. In fact, there are many situations in spine surgery we stop at L5, okay, especially when L5S1 doesn't look too bad in terms of degeneration. So when do we decide to go down to S1, and when do we therefore decide further that S1 is not sufficient and we need to go down to the pelvis, hence increasing the fixation requirements for this patient? So when truly do we do a limited stabilization or fixation in our patients? So let's go through one by one. First of all, we talk about whether we should just ignore fixation and just do a decompression, or should we just do a fixation away from the word go, okay? And the question we need to ask ourselves is really, number one, is the deformity or the pathology caused by a deformity? Is the symptoms caused by the deformity? So sometimes you have a subluxation of the vertebral body, sometimes you have a spondylolisthesis that is causing traction of the nerve roots. These are the situations whereby if you do not reduce the deformity, you will not be able to do decompression, and hence fixation is required. Sometimes it's a dynamic problem that the dynamism of the spine of the spondylolisthesis being unstable is the one causing the symptoms. And these patients, you really need to do instrumentation, or else there will be no relief of symptoms. And we are often asking ourselves the question, sometimes we do a decompression, we hope that decompression works, and it will work, but we're concerned that we may be iatrogenically destabilizing the spine, like how does a facet joint orientation look like, whether we are doing too many levels of multiple level laminectomies, destabilizing the posterior tension band. And these are considerations may push certain surgeons to do more instrumentation. And finally, when we talk about severe deformity like grade 4 spondylolisthesis, these deformities can result in sagittal imbalance of the spine, okay? And they can cause a lot of problems, okay, without restoring the alignment, and hence reduction, therefore instrumentation is required. We sometimes also see that in a spondylolisthesis with this kyphotic, or at particular FSU functional junction unit is kyphotic, the adjacent segment may be hyperlordotic as a form of compensation. This may stress that joint adjacent a lot faster in terms of degeneration, and hence there may be an indication for us to restore the alignment of the diseased joint now, and hence the need for instrumentation. So these are just two pictures showing the scenarios whereby limited fixation is good enough. In the coronal plane, where there is mild scoliosis, the spine is essentially balanced on the left side on the picture, and there's no need for a long instrumentation, hence limited instrumentation. The one on the right side really shows a focal pathology